Hello and welcome to #DocTalk Live. We are talking with oncologist Jonathan Lopez. He's going to be talking about how not all cancers are created equal. Take it away, Dr. Lopez.
Hi, my name is Jonathan Lopez and I'm a medical oncologist at the NorthBay Cancer Center. And I was asked to speak on breast cancer. And when I was thinking about breast cancer, I realized that there's not a lot of information that patients get when they talk to me about a diagnosis of breast cancer, that there's different types. There's a triple negative breast cancer, there's inflammatory breast cancer, there's HER2 positive breast cancer. And we always talk about lymph node staging or staging of breast cancer. So we'll start there. If someone's diagnosed with breast cancer, there can be a very, very early stage breast cancer that's confined to a small area and hasn't started invading, and that would be called a carcinoma in situ, and highly, highly curable with just surgery. Once the cancer starts invading, we have stages. We have stage 1, might be a small breast cancer, and if we look over at an image of the breast, and if you're a little squeamish, these are all drawn images. I do have a couple of photos of actual breast tissue, but so if we have a small breast cancer, maybe usually the upper outer quadrant, and but without any of the lymph nodes involved, and the lymph nodes are part of our immune system, which cancer can travel through. If a small breast cancer, that would be a stage 1, and maybe a little bit bigger breast cancer with one lymph node involved might be a stage 2 breast cancer. A stage 3 would be bigger with more lymph nodes involved. Now, all those 3 stages are potentially curable breast cancers, so we treat them aggressively dependent on markers that we find on the cancer cell. And then finally, the 4th stage of breast cancer is where it's gone to another organ, so maybe the bones or the liver or the lungs. And in that case, we don't have curative options most of the time. We have treatment options to extend life and improve quality of life. And I have a number of patients in my clinic now who've been diagnosed with metastatic breast cancer greater than 5 years ago, 7 years ago, and they're still doing well with some of these chronic therapies that they get. So for the typing of the cell surface, we look at and we're going to just zoom in on this little area here. So if this pink globe is a cancer cell, on the surface of the cancer cell we can find 3 proteins. One of those proteins might be estrogen receptor, and that's very, very common. About 2/3 of cancers either have estrogen receptor or progesterone receptor or both. And that would be a sign of a less aggressive breast cancer, usually happening in postmenopausal women, or even men for that matter, but postmenopausal women. And that would be called ER/PR positive breast cancer, by far the most common type of breast cancer. Or we can get a combination of ER positive, PR negative, HER2, this is actually called HER2-neu. This is a protein that's on the surface of about 20 to 25% of breast cancer cells in a patient, and that would be considered a very aggressive cancer. The good thing about having this HER2 marker, or HER2 positivity, is that we have direct targeted chemotherapies that can go right to that target. So if you have any combination of those, we call those positive breast cancer, positive for HER2, positive for ER, positive for PR, or any mixture there. But if the cancer cell does not express any of those proteins, then we have a triple negative breast cancer for the most common markers we look at to target. Now, if you're getting, if you have a very small tumor, less than a centimeter, and it's ER positive or ER/PR positive, maybe we just need to do a lumpectomy, take that out, do radiation to the area where we took the breast cancer out, and that patient can potentially start on a pill that they take every day for 5 years. That would be a breast cancer that's at low risk for recurrence. Of course, we do some other studies to make sure that it's at low risk for recurrence, but that patient might take a pill for every day for 5 years. Now, if it doesn't have those markers, but it has the HER2 marker, that's a sign of a more aggressive cancer, that patient would get chemotherapy plus a HER2 targeted therapy, and they would be on that HER2 targeted therapy in a stage 1, 2, or 3 breast cancer for about a year, but the rates of survival are much higher if we can target that. Now, if you don't have any markers to target and someone walks through the door and they have a diagnosis of a stage 1, 2, or 3 triple negative breast cancer, after surgery, the risk for recurrence is very, very high. We don't have targeted therapy that we can use, so we use chemotherapy in that case. And probably the only time we would not use chemotherapy is if the tumor were very, very small, and then we'd have to have a discussion about that. So that's what we mean when we say triple negative breast cancer. So with triple negative breast cancer, who does that affect? So now we know it doesn't express the ER, PR, or, and this is HER2, they left off the H, HER2 new. It's about 15 to 20% of all breast cancers. It's a little bit more aggressive, and chemotherapy is a mainstay of treatment. And it typically affects younger women, so even younger than the age of about 35. So if we have young women coming in, the likelihood is that it's going to be a triple negative. Our patients who are of African descent or Hispanic descent may certainly have an increased risk for the triple negative breast cancer. And anyone with a family history of breast cancer, a BRCA1 positivity, likely have a triple negative breast cancer. And that leads into males with breast cancer. You don't hear about that so frequently, but males can develop breast cancer, especially with a family history of breast cancer, and that can be a genetic predisposition. So any male who has breast cancer should be tested for the breast and ovarian cancer gene. So we can harbor that gene. So that's what the markers are, and that's why different breast cancers are not all created equal, and that some are less aggressive, and we have easier treatments, and some are more aggressive, and we only have chemotherapy for them. I wanted to talk about inflammatory breast cancer, because this is one that's a cancer typically of the young, and it's mistaken for infections of the breast. Very, very commonly, I'll see a patient comes into my office, and they've had 2 or 3 treatments for mastitis, inflammation or infection of the ducts of the breast. And after the 3rd cycle of no response and the mastitis is getting worse, that's when imaging is done and biopsies are done, and it turns out to be a breast cancer. So I think that in a patient who might be lactating or does have some irritation of the skin of the breast, since mastitis or even a cellulitis is very, very common, a course of antibiotics should be considered. But if it doesn't improve on that course of antibiotics, then very quickly thereafter a biopsy should be considered with imaging. And from a primary care standpoint, say you go to your primary care doctor, they might not be considering inflammatory breast cancer, given that it's only about 1 to 2% of presentations of breast cancer. It doesn't present typically with a mass, so it just looks like an infection of the skin. So it would have to be in the patient's wheelhouse of knowledge to say, hey, I heard of something that looked like infection on the breast, but it's really not infection. So that's a very common presentation for a patient to have had multiple antibiotic courses before they come to see me. So this is a drawn graphic. So I don't know if you can appreciate, but this is a breast. It's not reddened, but it has these little dimples on them. And those little dimples, we call that peel d'orange, I guess because the French make it sound so nice, but it's an orange peel type of presentation. Or we can have some dimpling and even blistering of the skin, or peel d'orange with some dimpling or blistering of the skin, without necessarily having a mass underneath it. It might just all be skin findings. And this is invasion of the lymph pathways in the dermis. So when we have the diagnosis of an inflammatory breast cancer, we jump past stage 1 and we jump past stage 2 and we jump right into stage 3 because we already know that it's advanced and it's in the lymphatic channels. So it doesn't matter the size, it's there's no mass typically, so it's within the lymphatic channels, and that automatically makes it a stage 3. And with that, we would have to do a biopsy to find out what are those markers on it, what are the treatment options that we have on it. Typically for inflammatory breast cancer, we would go right to chemotherapy to try to shrink it down so that we can get our best surgical control. Only if it's very, very small, and that's typically when we find out after the fact there was inflammatory, do we do surgery up front. Usually it's chemotherapy followed by surgery. Now and I'm a medical oncologist, surgery is the only curative intent treatment for breast cancer. If we leave it there, typically it will become immune to the treatments we're giving it, and it'll grow back. So all of our treatments are either designed to get someone to surgery with a better surgical outcome, or to decrease the risk of recurrence after they've had their surgery. Now this is another picture. This is a live picture. I think this shows the peel de orange better without a lot of inflammation. Just a inflamed breast that has a lot of fluid in it, and you can see the dimpling of all the hair follicles. Sometimes it just looks a little patchy. That can look as simple as psoriatic skin changes, or even maybe a fungal skin changes. But if it's on the breast, you have to think inflammatory breast cancer. So skin changes of the breast with maybe some edema or redness and swelling, not necessarily pain, you have to think inflammatory breast cancer. So I understand Kelly has some questions for me.
Well, hopefully. Can you explain in general what is cancer? Like, what is it doing? Like, what is it? Just in a general term.
Sure. So all of cancer cells are human cells. They're human cells that are dividing, and they forgot how to die. So normally we have cells, they divide a few times, and then the main cell dies. And that's called apoptosis. But if that cell has a mutation in the area that tells it when to die and how many replications, it just keeps on replicating and replicating. And then those cells will then mutate to a little bit different and a little bit different. And pretty soon we have a collection of cells that are no longer breast cells or blood cells or bone cells. They're just cancer cells that continue to replicate and mutate and replicate. And they become a mass, and sometimes they spread. And that's cancer in a nutshell. Now, cancer has learned how to evade our immune system. So if it becomes big enough to grow and us to detect it on imaging, it's evaded our immune system. Fortunately, we've come out with some nice immunotherapies that can overcome that evasion and stimulates our immune system to start attacking those cancer cells. Actually, that's one of the treatments, novel treatments that we have now for triple negative breast cancer that has metastasized is immunotherapies.
So thank you, Heather. Heather is saying you're the best doctor. You took good care of her mom. Thanks for tuning in. We also have a question from Martha. I've heard from several different people that believe cancer can be caused by what you eat in your diet. Is this a myth, or is there any research to support this?
So there are some weak studies out there and looking at cancer recurrence typically in, let's say for colon cancer. And if you eat excesses of anything, you might stimulate in somebody who is already predisposed to cancer, but in recurrence, they found in a very weak study that diets high in carbohydrates could potentially increase the risk of recurrence, but even that is a very weak study. There's some things that we think are associated, and we'll talk about more specifically, breast cancer. So patients who drink maybe 3 glasses of wine per week, that might increase their risk for breast cancer. And I typically say, because we know that if you drink maybe 1 or 2 glasses of red wine, that's 5 ounces, that's not the bottle, 5 ounces of wine a night, that could decrease your risk for heart disease. So if you have a strong family history of heart disease and no family history of breast cancer, you might want to weigh the risks and benefits and have a glass of wine at night. Although if you have a strong family history of breast cancer and no family history of heart disease, you might not want to consider that glass of wine like the other patients. So what I typically say is everything in moderation, and there's not one food that I know of that has been associated with cancer, but anything in excess, if you eat hot dogs every day, you potentially could get a GI cancer, and from all the nitrates that are in there. Yeah.
Well, let's ask the reverse question. Are there foods that help you in the battle against cancer?
So in patients who've had estrogen receptor positive breast cancer, they don't want to take in excess estrogens because that can stimulate a breast cancer that might be lingering there in a small form. So I would say avoid the cure your hot flashes now with this plant-based estrogen. So there are some foods that you could eat that would, if you have had a history of breast cancer, especially estrogen receptor breast cancers, that could worsen that. But now, let's say, for example, soy is a weak phytoestrogen. Women from Asia do not have an increased risk for breast cancer, and they have high soy diets. So we don't know everything about it. I wouldn't avoid all estrogen. Just try not to have a high estrogen diet. And you can't avoid soy. It's everywhere in the foods we eat. So just try not to go on a high estrogen diet.
There's a lot of news out there and stories about getting tested and seeing if you're at risk for certain kinds of cancer. And I think Angelina Jolie made headlines when she had a preemptive mastectomy. What are your thoughts on that?
We have a genetics counselor here. She's excellent, Karen Vikstrom. And if you have a family history of cancer, especially first-degree relatives, brothers, sisters, mothers, it would be reasonable to get a genetic screening to see if you're at risk for a breast cancer. I was talking to my wife and I said, you know, honey, 90 to 95% of all breast cancers are spontaneous. There's no genetic history about them, so you really need to get your screening. She was a little upset with me because she was hoping that it would be a higher genetic risk, and she's had no family history of breast cancer, so she thought she was safer than she really was. So I urge patients, even if you don't have a family history of a cancer, get your colonoscopy, do the mammograms, talk with your doctor about PSA screening, because if we find it early in a curable stage, then the chances for cure are very, very high.
So you talked about immuno-targeted medicines. What does that mean?
So our blood cells can attack invaders. So viruses, bacteria, cancer cells have developed, some cancer cells have developed a protein that inactivate our white blood cells from attacking them. Now, if we keep the cancer cells from inactivating our white blood cells and actually stimulate our white blood cells to go after foreign cells, then our own immune system can then potentially attack those cancer cells. So that's the upside. The downside is we have stimulated our immune system to start attacking cells, and sometimes we get a little crossover where it starts giving us what's called an autoimmune disorder. That's where the white blood cells attack our own cells. So that's the trade-off. But we've been getting some very, very good responses in cancers that used to be very difficult to treat with these immunotherapies. And if we can keep the side effects minimum, there's no nausea, vomiting, hair loss. It's usually the thyroid dysfunction and things that we really monitor for.
How do you determine with a patient like surgery versus chemo or some combination of surgery and chemo, and what goes into that decision?
Well, if we're talking about specifically breast cancer, if we have a stage 0, and that's that carcinoma in situ, 1, 2, or 3, there's going to be surgery within there. Otherwise, we're not going to be able to cure that cancer. If there's a stage 4, it depends on the cancer type whether there's surgery or no surgery. But typically in a stage 4 cancer, that's not curable, so those patients get treatments with either chemos or immunotherapies or a combination thereof to try to control the disease. And in some rare cases, we will offer surgery if we're able to get those cancers under control, where we can take out the one lesion that might have gone to the liver, and we do that in colon, and sometimes it's more than one. But if it's, as a general rule, if it's early stage and it's curable, there'll be surgery involved with it. If it's later stage and incurable, there's no surgery involved with it. But now, if we look at cancer groups, there are 3 main groups: carcinomas, lymphomas, and sarcomas. Lymphomas, they don't get surgery, they get only chemo, and we can cure lymphomas and leukemias with chemotherapy. So right now I'm sticking with the solid tumors and not the blood-borne tumors.
Okay. Some people say there is cancer in their family. If someone has family members that had different types of cancer, do they all add up to make someone at higher risk in general?
That's a really good question, and that's why we have Kieran Vikstrom as our genetics counselor, to go through an algorithm to determine, are these separate cancers associated with one gene that might put that family at risk. So if there's different cancers within a family, I would say see if you can get genetic screening.
And how do they do that? How do they get genetic screening? Do they have to get a referral from the regular doctor, or do they just call up and say, hey, I want genetic screening?
At NorthBay, if you go to your primary care doctor and they send a referral to the genetics counselor, and they're right here in the cancer center, and she can do a video visit. Sometimes we take a little scraping from the inside of the mouth, just some cells there. Sometimes we take blood, and within about 2.5 weeks, we'll have the results, and she can go over those results with you.
So, what about radiation? You talked a lot about chemo and surgery, but where does radiation come into the treatment plan?
So for breast cancer, if a patient has a lumpectomy, and that's where we just remove the lump and the margins around it, so we physically removed all the visible cancer. If we add radiation to that, then the survival outcomes are the same as if we do a mastectomy, where we take the whole breast away. Now there's occasions where we use radiation if we've done a mastectomy, that's where we remove the whole breast. But if we have a small cancer and we remove the whole breast and there's no lymph nodes involved, then there's no radiation involved. If we just remove the lump, then there's radiation involved to make the outcomes equivalent.
How common is recurrence in breast cancer cases?
So if we have an early, and it really depends on stage, if we have an early stage breast cancer, and say that breast cancer is 1 centimeter without any lymph nodes, the likelihood for cure after surgery and radiation, if we do a lumpectomy, is about 90%. We might be able to improve that by 5% with other therapies. So then that would mean a 95% cure rate, and 5% of those cancers recur. Now that risk gets higher the higher the stage. Stage 2's risks for recurrence are higher, stage 3 risks are higher, and of course stage 4 is already metastasized.
And typically speaking, how long does chemotherapy last?
So if it's if we have an early stage breast cancer, it might be about 4 to 6 months. If it has that HER2 positivity on there, it would be about a year. If we have metastatic breast cancer, it's typically ongoing. Now, that's the chemotherapy portion. If we have that estrogen receptor positivity, the ER positive or PR positive, we add a anti-hormonal agent, either tamoxifen for premenopausal women or Arimidex letrozole for postmenopausal women, and they take that every day for 5 years.
So if someone had triple negative breast cancer, why should they go through genetic screening to help inform family members or children?
Right, and if you have a triple negative breast cancer and you're young, and you find that you have the breast and ovarian cancer gene, that would put you at a high risk for ovarian cancer too. You might want to consider, if you're still raising a family, having another child, because then we would want to remove the ovaries and fallopian tubes. And also for if you have a brother or sister who could potentially carry that gene, and then for your children as well.
How long do you have to be cancer-free to be considered cured, if that's the right word?
Cured, well, I usually say no evidence of recurrence of disease. And we use the magic time frame of about 5 years. And I believe the 5 years is used was because that's how long studies followed patients out. And after 5 years, they moved away and our study values went down. So we typically use 5 years. It's very rare to have patients have breast cancer recurrence after that, but it can happen in very slow growing, very indolent, usually estrogen receptor positive breast cancers. I've seen them come back at 10-year mark, and we put them on a pill typically that they take once a day, and it controls it. And I have maybe 3 or 4 patients in that category right now, and then they're doing very well just on oral therapies.
Joanna is asking a question, and I think she may be a woman after my own heart because I can sense her feeling about mammograms in here. Is a mammogram at 40 really necessary? Can it be pushed out a little?
There are different colleges, and I'm finding that our screening is getting better and better, and we can detect cancers at an early age. So if you start at 40, I think that could relieve your mind. And I agree. The mammogram is not ideal. If the testicular exam was the same, we would change the machine, but it's not. So I would say that the earlier screening, the better, especially with a family history of breast cancer.
Okay. We're almost out of time. Oh, we have a question here. When is a breast MRI a good idea for screening?
So if we have someone with very, very dense breasts, and typically the radiologists are very good at making those recommendations. If they find that there's some areas that they can't see through with a mammogram, then they might recommend an ultrasound and or an MRI. And so in patients who have the breast and ovarian cancer gene, usually we alternate mammogram 6 months later, MRI 6 months later, mammogram. So those patients with very, very dense breasts who have a finding that we need to evaluate more, or those patients who are breast and ovarian cancer gene positive, starting at a younger age.
Is the MRI different from the 3D breast cancer that we're doing? Or breast
an
exam?
MRI is a magnetic resonance imaging, and you lay in a machine, and it's very, very loud, and it takes a long time, as opposed to the 3D mammography.
But we do offer 3D mammography.
We offer them
also.
both,
Yeah.
correct.
Okay. All right, I don't see any other questions, and we're just about out of time. So we want to remind you all to join us November 17th at 5 p.m. when one of Dr. Lopez's colleagues, Dr. Marengo, will be talking about reconstructing life after breast cancer. And then on November 18th, we have Dr. Kara talking about robotic surgery in urology. So thank you, Dr. Lopez, for taking time out of your busy day. We appreciate it so much.
My pleasure. Plug for Dr. Marengo. I've seen many surgical outcomes from many different surgeons. We are privileged to have Dr. Marengo here. He's a highly skilled surgeon, and I do not believe you'd find better in Sacramento, San Francisco. You'd probably have to go down to LA and wait in line for 6 months to get somebody as skilled as Dr. Marengo.
Wow, wonderful. Thank you so much, everybody.